Good evening, aspirants. Good evening, sir. So, the topic for today is trauma and burn. It is class 2. And the speaker that we have here is Dr. Avishek Roy, Associate Consultant ICU at Apollo Multispeciality Hospital, Kolkata. Thank you, sir. So, you may take over.
Good evening, everyone. The first class we covered the general trauma concepts like primary, secondary, and tertiary survey, and then we went ahead with discussion about the chest trauma. Just a quick recap of of the important points. That first of all, whenever a patient with trauma comes, we have to evaluate the ABCDE: A for airway, B for breathing, C for circulation, D for disability limitation, and E for exposure control or environment control. And the important points we have to take note of is what is the patient's consciousness, whether to intubate or not, what is the level of breathing, whether to put a chest tube or not, how will you manage hemorrhage. And greater discussion on hemorrhage and hemorrhagic shock was done in the last class. Then we come to the risk assessment of the neurological status by GCS score, and afterwards environmental exposure control, hypothermia management, etc. And then we discussed a lot on chest trauma. So now we'll move ahead with one or two small topics, and then we'll go to larger topics. So today's discussion will be on small topics like fat embolism syndrome and compartment, and then I'll go to in general torso trauma, that is the abdominal trauma, and because chest trauma is covered, and then we'll have a discussion on the brain injury. So quickly I go through the first topic, which is fat embolism syndrome. Very important for any kind of exams, whether be it formal exams or MCQs. So it is the definition wise, it is the phenomena of severe biochemical and mechanical manifestations of multiple fat microemboli in the system. So because of which we have different aura of manifestations. So the basic thing, the systemic manifestation because of fat emboli into the circulation. It is a rare phenomena altogether, but in a trauma setup it is very common, and it is seen mostly in patients who have long bone injury or long bone fracture, especially femur fracture, humerus fracture, tibial fracture, and rarely pelvic injury and trauma can also cause that. So the etiology, obviously, with it is a trauma topic, so etiology is by far the most common. 90% cases would be trauma, and especially long bone trauma. Why? Because long bone have bone marrow. Long bone have a larger amount of marrow, and the marrow is functional in adults as compared to vertebrae and everything. So that's why it is much more common with long bone. Except for traumatic cases, we can also see fat embolism in medical cases like acute pancreatitis, if you give too much amount of total peripheral nutrition or total parenteral nutrition TPN back rapidly to a patient. Sometimes with propofol you can have a fat embolism syndrome, and then you can have in severe some cases of sickle cell anemias and all can also have. But let us stick to our topic. So trauma. The risk factors are mostly long bone fracture trauma. As I said, there are two theories proposed why fat embolism syndrome manifests. One is a biochemical theory, one is the mechanical theory. Now we can easily think that if there is a what happens, what is fat emboli by the way? So if there is a bone fracture, what will happen is, if you can see, there are multiple vessels surrounding the bone marrow, and then suddenly because of the fracture, this cerebral fat within the bone marrow will enter into the circulation, and then from there onwards will have dissemination into the system. That's the basic concept. So very easily we can think, okay, it is a mechanical thing. Because of the microemboli that shower into the system, they will go and they will clog multiple vessels and cause the manifestation. So that is the basis of your mechanical theory. But it is not the most common or the traded complication, or the pathophysiologically wise. What happens is a biochemical thing. After it enters into the circulation, it causes a severe systemic inflammation. There is an increased amounts of TNF alpha protein, IL-6, IL-1, and TNF alpha that is secreted into the system, and because of this severe inflammation, along with inflammation comes vasoconstriction. So because of the vasoconstriction and inflammation, there is increase in the pulmonary arterial pressures, there is increase in the right ventricular pressure, there is clogging of the pulmonary arterial system, and therefore we get the hypoxia, the altered sensorium, you get clots and the vasoconstriction in the brain. So you get cerebral microembolism as well as you get all the skin manifestation. The clinical signs are mainly the triad of hypoxia, skin manifestations like petechial rash, especially in the upper body part, upper torso, and altered sensorium. So these classical three features, if it is present in a patient who has a long bone trauma, usually within 24 to 72 hours, that is classical of fat embolism syndrome. So this is very important to note. Each and everything can be asked in the exam. So 24 to 72 hours is the timeline. It can occur although till 5 days, but it rarely occurs after 7 days. So the peak period is 24 to 72 hours, and the classical trait of hypoxemia, petechial rash, and altered sensorium. The respiratory manifestations can range from mild hypoxia requiring low flow oxygen to severe hypoxia and ARDS like features. Neurologically, they can have altered sensorium, they can also precipitate seizures, and they can also land up in coma. And they have a petechial rash, especially in the upper body part, like this shown in the picture. You have small red kind of rash that is spread in the upper body part, and it can also see it in the conjunctiva. Now, there are scoring systems for diagnosing fat embolism syndrome. Mainly, there are two scoring systems. That is, one is Gard's criteria, one is Kornfeld criteria. What is Gard's criteria? There is major and minor criteria. Very easy to remember. Major criteria is all the three that I have said: hypoxia, altered sensorium, and petechial rash. The minor criteria are multiple, like you can have fever, tachycardia. You have to look at the retina to diagnose microhemorrhages. Then the patients can have jaundice, they can have thrombocytopenia, they can have high inflammation and indicated by high raised ESR, and you can see fat microglobules in the urine. That is one of the previously used diagnostic tests. Nowadays we don't use it. We only judge based on clinical parameters. The other criteria which are also used are Lindekis criteria and Schonfeld. The Schonfeld and the Lindekis are important because it has a PO2 level. Hypoxia, it's categorized as PO2 less than 9.3. In Schonfeld, they have given particular marks, scoring marks to particular symptoms. If you have a petechy, you have the highest marks of 5. You have the chest X-ray, it is 4. I mean, chest X-ray showing bilateral infiltrates, ARDS type or patchy opacification. It can be have fat embolism. And then hypoxia 3, confusion 1, and the rest others are 1, fever, heart rate, tachypnea. If your total score is more than 5, you have a diagnosis of fat embolism syndrome. Again, I am saying it is a clinical diagnosis. You don't need to send a specific lab investigation for diagnosing. Second, another scoring system is the Lindekis. It is as similar as Kornfeld. It has got the criteria for PCO2 as well, along with PO2 criteria. So the Schonfeld is much more better as compared to GARDS. Why? Because GARDS is based on clinical criteria. You have to have hypoxia and respiratory distress to diagnose. But if the patient is not having distress, still the patient can be hypoxic. That's why we need to do an arterial blood gas to diagnose the hypoxia based on PO2 levels. So the Schonfeld diagnosis subclinical fat embolism based on the arterial blood gas. That's why Schonfeld is slightly better as compared to GARDS. So this is the chest X-ray showing bilateral diffuse patchy opacities which is seen in fat embolism, and this is a cerebral, I mean MRI of brain showing a T1 and T2 phases, multiple small, you can see hyper intense lesion around the the ventricle, and along with the third ventricle, the corpus corpus callosum, and some of the subcortical structures as well as the posterior horn of the lateral ventricle. So this is known as the star field appearance or the starry sky appearance of MRI, which is classical of cerebral fat embolism syndrome. Next is we can also look at the retina, because eye is directly connected to brain and eye is the kind of the gateway to look at your brain. If you look at the retina, you can find multiple small coronal spots and you can find some blotch hemorrhages. These are the most common symptoms of retina. I mean findings in retina. Now coming to the treatment is supportive, only supportive care. You have to give adequate analgesia, you have to give oxygen support, you have to give anticoagulation. Very important, these patients are having very high risk of DVT because they have a fractured limb, they are immobilized, so they have a high risk of DVT. So you anticoagulate and just give them supportive care. They generally come out of this syndrome within 2 to 3 days after they are diagnosed. Other than that, there are multiple experimental therapies that have been tried, like steroids, anti-inflammatory agents, statins, even heparin and um, aprotinin has been also been tried, but these are all having no evidence to use. Heparin, someone can ask what is the mechanism. Heparin is shown to stimulate lipoprotein lipase. So imagine that you have five fat microglobules in your serum, and heparin goes and cleaves them, and therefore releases the fat microglobules, breaks them. That is the mechanism of heparin. So heparin theoretically has a advantage or can be used in fat embolism syndrome. Similarly, and protease activities, aprotinin is a protease inhibitor. It degrades the platelet aggregation, so that's why it decreases the biochemical reaction. Again, theoretically can be used. Now, the main thing, next part of the discussion is abdomen and pelvic trauma. Now, this is a huge topic, and to be very frank, questions seldom are asked from this concept. So, I will quickly go through the main important parts that are important for clinical practice, and secondly, for exam purpose, we have to know very basic few things in this concept. So, we'll cover the blunt trauma abdomen, penetrating injury, organ injuries, few pelvic injuries, and compartment syndrome. So abdomen can be divided in four regions: upper abdominal part, thoracoabdominal area. So this is the upper abdomen, anterior thoracoabdominal area. We have the posterior thoracoabdominal area. We have got the two flanks, and we have got the back. Mechanism: it could be blunt trauma, like you can a passenger sitting inside a vehicle, getting crashed into some other vehicle or some truck, heavy vehicle, and getting trauma in the anterior or the posterior or the side part of the back of the abdomen without any penetrating injuries. There can be penetrating injuries as well. Now, it is important to differentiate a penetrating from a perforating injury. Penetrating is when you have an injury that has only entry wound, you don't have an exit wound. Supposedly, someone gets stabbed, so that knife has an entry but it doesn't have an exit. So that's called a penetrating wound. And if you have a entry as well as an exit wound, then it's called as a perforating wound, which is most commonly seen with a gunshot wound. So this is a very basic difference. So blunt trauma abdomen seen in most cases of road traffic accident. Mechanism and multiple. Generally, a person sitting inside a car is generally their abdomen is squeezed between the wheel as well as the seat, or it could be because they are from any other. It could be because of multiple mechanisms are there. I'm not going to the details of mechanisms. So it could be because of direct flow, and many a times it is an indirect injury because people are wearing seat belts, and seat belts are strapped around your neck area and the abdomen. So that can cause seat belt injuries. So the seat belt injuries are classical, and there are few important things to remember about seat belt injuries. And the shearing injuries can cause crush injury, and that can also result in abdominal compartment later on. And it can also be result from decelerating injury. Suddenly, a speeding vehicle coming to a sudden halt, and then that wheel is getting struck on the abdomen, that can also cause injury. It can also be as a result of side injury. Previously in class, we said that during secondary survey, we have to address the ample of a patient. What is ample? Ample stands for allergy, medical history, past medication, past medical history, last meal taken, and event that has led to this accident. So before going in depth about the patient, so if the patient is having a hit, injury, you stabilize, and then you inquire about the history of ample and the speed of the motor vehicle accident, the mechanism of injury, and who else was traveling, how many of injured. So all these things give some clue about what are the things that we're looking at. Seat belt injuries results in injury. It can result in injury to the neck because seat belt is obviously coming from the neck, and then it is going across the abdomen to the slot in the back. So it can cause spinal fracture, flexion distraction injuries at C71 multiple levels. It can cause thoracic rib fracture. In abdomen, it can cause pancreatic injury. Very, very important to remember that pancreatic injury and mesenteric tear are very common in seatbelt injuries. Similarly, if you have steering wheel injury, you can have rib fracture, you can have commotio cordis, that is a blunt trauma to heart, you can have bowel perforation, liver and spleen laceration, etc. But to be very frank, by the time of this kind of patients come, you'll get an ultrasound done or a CT scan done, so you get a full delineation of what injuries you are dealing with. So you don't have to think too much about the mechanism and what are the other injuries, because you get a whole body CT scan and you get an entire idea about what are the injuries present in the patient. Few words about the penetrating injury. It could be because of knife, it could be because of gunshots, and in those cases there is something known as a local wound exploration. We'll come to the details. The shotgun wounds, there is a peculiarity about it that if they are fired from a small distance, like less than 2.7, they cause greater damage because obviously the energy percolated on the body as well as the amount of soot and particles that goes through the body is massive. That's why they cause more damage. But if they are fired from a long shot, they cause less damage. But if it is a updated gunshot or gun use that is in modern era, they can cause havoc damage even from distance. So you have to examine the abdomen. You have to see if there is any local signs that indicate abdominal trauma, any subswelling, any mass-like feeling, organomegaly, free fluid. These are all things you should be looking at. Routine routine digital rectal examination may not be helpful in acute cases, and you have to examine for things like this. This is the Cullen's and the Great Turner sign, the periumbilical site hematoma and a flank hematoma, which is actually described in trauma, but later on came to be described in pancreas as well. Similarly, you can have a splenic laceration, and that can irritate the left side of the diaphragm, and the left side of the diaphragm in turn is innervated by C3, C4, C5, and that can have a referred pain to the left side of the shoulder, and this is known as the Kehr sign, Kehr, Kehr sign. Diagnostic test. Now, very important to focus on this part. What are the diagnostic tests of a blunt trauma abdomen? So, foremost is to understand the focused assessment of sonography in trauma. We can also go for CT scan, and there is something known as the diagnostic peritoneal lavage. In addition, we can also go for X-rays, MRIs. Those are always options. FAST is obviously a revolution in the genre of trauma management. It is a bedside curvilinear probe of the ultrasound that is used to diagnose free fluid within the abdomen. And the areas that we target are 5. 4 in acute in FAST and 5 in EFAST. So 4 areas are hepatorenal pouch of Morrison, left-sided splenic creases, then you have the suprapubic creases, and in other than these 3 areas, we have and the epigastrium obviously. And other than these 4 areas, if you are looking at the costophrenic angle, basically looking at the chest to diagnose pneumothorax or hemothorax, then it is called as the EFAST, extended FAST. So EFAST is when you have FAST of the abdomen plus the thorax. This is the very basic thing to understand. Now, in ultrasound, we are looking at free fluid. So it is able to diagnose a hemoperitoneum. If you have an acute free fluid, diagnosis of hemoperitoneum is made. Patient has to be taken to the OT for operation. That's the most underlying meaning. But what are the limitations? So imagine you are doing an ultrasound on a patient to find out fluid in the abdomen. If you have a hollow viscous perforation, you might not get fluid. So it is unable to diagnose hollow viscous perforation or diaphragmatic tears. Secondly, sometimes it could be limited by the the dressing or the patient's attires, etc. And it takes time for the fluid or the blood to accumulate. So if you have a small amount of fluid or blood, it might not get detected. And in patients with pre-existing ascites, and supposedly a patient is known case of CLD with ascites, you will not be able to identify whether it is a new onset blood or the old ascites that is masquerading as a fast positive lesion. And ultrasound is only able to penetrate till before the retroperitoneal. So if you have a retroperitoneal structure, it is unable to pick out. So studies suggest that the lack of bladder distension is a major reason that the pelvic free fluid is missed, and therefore if you want to diagnose pelvic pathologies, you have to inflate the bladder or inflate the bladder with some saline so that you can visualize. So first, very important to remember that the main limitation is retroperitoneal structures are not seen, and old fluids can be misdiagnosed as new fluids. So in that case, obviously we have to rely on the CT scan. There is a entity known as diagnostic peritoneal lavage. What is this? Now, it is basically putting a catheter inside the abdomen and lavaging the entire intra-abdominal contents and getting the contents out of the abdomen and examining them, whether it is blood, whether it is bowel contents, and whether it is exudative sometimes. So the examination of the intraperitoneal contents by putting a catheter. Now, what are the indications? Indications are very, very few. Number one, we have to understand that in the era of ultrasound and in the era of CT scan, putting a catheter, that too in blind technique, it is not to be recommended. If you are drilling a patient in a non-tertiary setup where you don't have a backup, and your one blunt trauma abdomen comes to you, you don't have time to send the patient to a referral center, then to diagnose whether the patient has any diagnostic, possible abdominal pathology or not, you can do that. In current days practice, this is the only scenario where diagnostic peritoneal lavage is used. So evaluation of hemodynamically unstable patient where your uh, you have a lack of proper care or proper escalation, then only you can do a diagnostic peritoneal lavage. So how to do that? You have to prepare the abdomen, sterile technique. You have to put nasogastric tube and Foley's. It is mandatory. You have to decompress the stomach and the bladder. Mandatory. Otherwise, you cannot do. Then, 2 centimeters below the umbilicus, you have to identify your needle site. Then you can do three things. One is open, semi-open, and closed. What is closed? Closed is just like putting a central line. You put a needle, you thread a guide wire, and then you thread a catheter. If you are unsure about this closed technique, you can use a semi-open technique where you take a small incision, a stab knife incision, then you basically put the needle and then you put the guide wire and then you put the catheter. Or you can completely go to an open technique where you use the scalpel full depth till the fascia, put the guide wire inside the abdomen and then put the catheter. After this, you have to gently aspirate. On aspiration, if you find that there is directly blood is coming, that means there is blood inside the abdomen and that means it is hemoperitoneum, you have to open the patient. That is, you have to go for laparotomy. But if you see that the blood is not coming, but then you go for some lavage, you instill 1 liter of normal saline or ringer lactate and then you take the samples out. If you see that on the taken out sample, RBC number is significantly high, like more than 1 lakh per millimeter cube, or the WBC number is more than 500, or you see that bowel contents like food materials, like stool particles are coming out, or there is significant amount of bilious contents are coming out, that means there is a possible or positive DPL. Means DPL is positive, patient most likely has an intra-abdominal pathology, and you have to call a surgeon to get a laparotomy done. That is a diagnostic peritoneal lavage. Again, to highlight, it is done in areas where you don't have availability of appropriate imaging, and you have to manage a patient in an emergency scenarios, hemodynamically unstable patient. So that is one very important thing to remember. Now coming to the other next part of the discussion, obviously the best modality to diagnose is CT scan. You go for a CECT, and the benefits are much larger than disadvantage. Disadvantage would be something like cost, contrast-induced nephropathy, which are easily so not so much of an issue in an acute trauma case. Now coming to a small comparison of the techniques. So DPL is only to be done in a resource limited setup as an emergency measure, hemodynamically unstable patient. Techniques I have discussed. Major drawback, obviously we have not discussed the contraindication, obviously, but I forgot to mention the contraindication. So main contraindication for this is when you have a definite indication of laparotomy. You have the patient has come with blunt trauma abdomen, you have put the ultrasound and you have seen definite blood. You will not go for DPL. Similarly, if you don't have you have an availability of appropriate imaging like ultrasound and CT, you don't need DPL. Or you have pelvic fracture. Why pelvic fracture is a contraindication is that you are introducing this catheter 2 centimeters below the umbilicus, and pelvic fracture can extend the hematoma anteriorly, so it is relative contraindication. Although you can go for a supraumbilical incision here. And then pregnancy, full bladder, unable to put a urethral catheter. If your bladder is full, you cannot do a DPL. So these are the relative contraindications of DPL. CT scan, just now I said, so it is not so, it is the best modality as I say. Other than that, if you have a stab knife, you can go for a local wound exploration under local anesthesia and decide on the what is the depth of the incision, whether peritoneum is breached, and if peritoneum is breached, there is chance of peritonitis. Therefore, the open surgery like laparotomy is required. Thus, diagnostic laparoscopy has got limited value in the case of trauma. However, in some settings where the patient is relatively stable, it can be done to diagnose the extent or smaller kind of diagnose and manage smaller intra-abdominal pathologies. Coming to a brief overview of how a patient is managed. If a patient with blunt trauma abdomen comes, and if the patient is hemodynamically unstable, you do a fast. If the fast is positive, patient is taken for OT. If the first is not done, you can go for a CT or a DPL, DPL in a resource limited setup, CT in a proper setup, and decide on the further injuries. Similarly, if the patient is not communicating, like you, patient is inebriated, patient is intubated, or patient is having some head trauma, if you suspect abdominal pathology, similar finding. You go for a first is positive, go for OT, first is negative, you get a CT done, diagnose the injury, and then decide onwards. And next, coming to stab injury, I'm not going to details. Gunshot injury management is overall the same. That the basic funda is that if the patient has signs of peritonitis, intraperitoneal breach, we have to open the abdomen and we have to go for proper surgery. That's the basic two things that we have to remember. And obviously, in these cases, we have to go for prophylactic antibiotics to prevent future infections. And there is a limited role of ED thoracotomy. Like if the patient has come to emergency department and patient has signs of life, but in front of you patient just collapses or has signs of or asystole, that means it is an indication you have to go for emergency thoracotomy. You have to open the chest, you have to go for cardiac massage. So the why would that happen? If the patient is having signs of life in front of me suddenly collapses, could be a massive commotiocarditis, could be a massive traumatic pericardial tamponade, could be pneumothorax, could be hemothorax, etc. So in these cases, you do a open thoracotomy immediately. You do the cardiac massage, you identify the pathology, and try to save the patient. Even with ED thoracotomy, the mortality is as high as 60 to 80% in these patients. So it is a dire situation. There is something known as REBOA. Supposedly, if a patient has come with obvious bleeding and the source of bleeding is distant to distal descending thoracic aorta. I will repeat myself. The aorta has got mainly three parts: ascending arch and descending thoracic aorta, and descending thoracic aorta continues as abdominal aorta. Anywhere other lower than the descending thoracic aorta, if you have a bleeding structure, you can occlude the bleeding by putting a retrograde tube or retrograde balloon through the femoral artery into the aorta and inflate the balloon cuff so that it occludes the blood vessel blood flow distal to the occlusion site. Obviously, this is a ischemic maneuver, so you have to take the patient to OT within half an hour to 1 hour to preserve the lower part of the body and to maintain proper homeostasis. This is just a temporary hemostatic measure. If the patient is not in a setup where surgical team and emergency OTs and REBOA tape teams and managing is not adequate, you simply don't put the REBOA. This is called as REBOA, resuscitative endovascular occlusion of the aorta. Coming to a brief overview of the organ injuries, so the major visceral organs or the solid organs that can be injured are liver, spleen, the pancreas, and in some cases hollow organs like gut can be injured. Kidneys obviously is an important structure. Now, one thing you have to understand: these are the concepts of trauma care that I'm saying. If you have a patient who has a head injury and an abdominal injury, you have to look out for a chest injury as well, because chest is in between the head and abdomen. Similarly, if the patient has a chest injury on the right side, rib fracture, pneumothorax, hemothorax, you have to obviously look for a liver laceration because that is in continuity with the just below the diaphragm. So, having a knowledge of the basic anatomical structures and the possibilities of different trauma to different underlying structure is very important. So, liver laceration occurs in various ways: direct hit, blunt trauma abdomen, fall from height, anything can cause a liver laceration. The grading of laceration is 1 to 5 as per the international society's guidelines, and as per the World Society of Emergency Surgery, it is categorized to three parts. So one society categorizes as 1 to 5, one society 1 to 3. But basic difference, we cannot memorize all the things. It is not possible for a intensivist to memorize the grading. What is very important to understand is there are two things, rather three things, to determine the extent of a liver injury, splenic injury, and renal injury. Those are the depth of laceration of the parenchyma, the subcapsular hematoma, and any kind of vascular laceration or vascular avulsion, major vascular event. These three things we have to see. Any patient who has a limited laceration, limited hematoma, no vascular injury is a low grade injury. Higher laceration, higher hematoma, but no vascular injury, intermediate. And greater laceration, significant hematoma, and any extent of vascular injury is always severe injury. be it liver, be it spleen, and be it kidneys. Now, there is a difference to how you approach the three organs or three solid organs. Liver and kidneys are mostly managed non operatively or conservatively as much as possible till grade 3 or grade 4 also. If the patient's blood pressure is holding, the organ is functioning well, there is not much of a hemodynamic deterioration, not much of an infection, you can just manage non-operatively. Whereas spleen is an organ where you have grade 3 to 5 injuries. Generally, if there is a non-salvageability of spleen is proven, you go for a surgery in the early phase. So spleen, more, I mean, non-operative obviously is preferable, but the threshold for doing a operative intervention is lower. Liver and renal, kidneys, they have threshold for operative intervention is slightly higher. These particular cutoffs you don't have to remember. And the basic thing that I've said, that if the patient is hemodynamically unstable, and as I said, if there is a spleen trauma, you have to open and go for a splenectomy or splenography. If the patient is stable, you can go for a ultrasound and CT, and define whether that is intermediate, mild, or moderate lesion. In some cases, if the patient is stable, but during discharge, what you can get is get a CCT abdomen done and look at presence of any pseudaneurysm. This is very important to understand. Sometimes what happens is there is a trauma and then patient is stable, you let go of the patient, later on patient comes with a huge bleed and dies. So basically during trauma there is a vascular injury, and that vessel basically gives away, leading to an aneurysm formation. If the aneurysm is positive, you have to go for an angiography and coil the aneurysm. And if the aneurysm is kind of stable, not causing any significant problem, normal in size, then you can just let it go and keep it, conservatively managed. So angioembolization of a big sized blush or huge sized aneurysm is important, both for liver and spleen. Both these cases both are important. So hepatic trauma, as I've said, the basic few fundamental things I have already told. Similarly, spleen trauma is also the I have told. Pancreatic trauma, less commonly encountered, but sometimes in seatbelt injuries it can be the sole organ involvement because it is packed between the intra-abdominal contents and the thoracolumbar vertebra, and it gets jammed and then it gets fractured. If the pancreatic duct is ruptured, it can cause traumatic pancreatitis. It is one of the most deadliest combination or injuries that a person can have. Liver and splenic injuries are far better than having a pancreatic injury, because once the pancreatic enzymes are in the abdomen just gives way and then it basically denudes itself. So diagnosis for pancreatic trauma is to be done by use of ultrasound and CT scan. Obviously, it is a retroperitoneal structure, so ultrasound has got limited role. CT is getting better role. There is some role of sending a intra-abdominal peritoneal amino lipase. However, they can be non-specific because it could be elevated in bowel injuries, torsion of the any intravascular, any solid organs. So it is can be non-specific, especially in the context of trauma. But there is some limited role. If you get amylase lipase elevated, especially after 24 hours of pancreatic enzyme, pancreatic trauma, because within 24 hours it is definitely non-specific. After that, if it is elevated, it indicates there is severe traumatic pancreatitis. You might need to go for an open surgery and pancreatectomy. So that is all about the intra-abdominal hollow organ injury. Renal injury almost the same as splenic and liver injury. That if you get milder forms of injury, you can go for non-operative management. Severe form avulsion, you have to go for nephrectomy. In between somewhere, you go for an intervention radiology guided maneuvers like any embolization or coiling of the pseudaneurysm formation. Now coming to GIT is not so important. So, hollow viscous perforation and trauma, if there is complete transaction of the bowel, you have to go for open surgical intervention. Few words on pelvic fractures. Pelvic fractures can be of multiple types: anterior type, posterior types, lateral type, open book, and multiple types. The main issue with pelvic fracture is acute hemorrhagic shock and bladder urethral injuries that can cause extravasation of urine and subsequent infection. That is one of the worrisome things. And obviously, some cases, because it is so tentatively close to the neurovascular bundle, neural damage and then subsequent cauda equina syndrome and conus pulmonaris syndrome, this can happen. The pelvic ring is composed of two pelvic alli, the pubic ramus, superior and inferior, then the symphysis pubis, and it is joined together by two parts. Posteriorly, it is joined by the sacrum, and anteriorly by the symphysis pubis. These are the various ligaments: the symphysis pubis ligaments, the ischiorectal, ischiotuber, ischios, anterior sacroiliac ligament. You have the sacrotuberous and the sacrospinous ligaments. These are the basic structure that forms a pelvic anatomy. The lumbosacral plexus and the branches of the internal iliac artery that emanates from the underlying structures are going through these structures. So in a nutshell, it is an extremely vascular and neural structures that lies close to this sacrum and this pelvic region. So it can be result of motor vehicle injury. Very commonly, fall from height of around 12 feet or onwards can cause a pelvic injury. The pelvic injuries are unstable or stable. Stable injuries are where one of the side is gone, but it is not so unstable that it opens up. But unstable injuries are sometimes what happens is like this: open book fracture. So you have a open book, like you open the book, you are opening the pelvis. So anteriorly the pelvis opens up like you're opening a book. So entire symphysis pubis is gone, along with the posterior connection is also displaced. This is called as the open book injury. You need to immediately go for pelvic stabilization and surgery. One of the tests that is performed to diagnose pelvic injuries is pelvic compression test. It is very simple test. You compress the pelvis anterior posteriorly and then laterally, and then you see look for any kind of pain if the patient is awake and able to tell you. But again, it is a gross technique. Sometimes if the patient has a pelvic hematoma that is clogging the artery and not letting the bleeding, if you do this pelvic compression, the hematoma can, or the clot can get dislodged and can cause significant bleeding. So that's it with pelvic injuries more or less. And this is the pelvic binder that is applied to patients who have a pelvic injury. So this is one way that is done. That is, bed sheets are wrapped around the pelvis and the clamps are applied. Pelvic C clamp is another technique by which you can apply. You can non-operatively close the pelvis and go for compression, stabilization of the pelvis ring, and then you can go for open surgical external fixator application. Long bone fractures we have already discussed. The main thing about long bone fractures for a intensivist is to know about fat embolism syndrome. What is compartment syndrome? Compartment syndrome is can be traumatic or atraumatic. It is basically a clinical diagnosis. Again, like fat embolism, compartment syndrome is a clinical diagnosis. So whenever a closed compartment like abdomen, like anterior part of the leg and the thigh, they have trauma and then they have significant muscle edema because of the compartment pressure rises, and it is a closed space. It is a deep fascial closed space. It basically compresses the blood vessels and causes ischemia. That is the basis of compartment syndrome. Compartment syndrome can happen in abdomen, in the extremities like upper limb and lower limb as well. The most common site is the anterior leg. That's why the extensor compartment of the leg, anterior compartment, is the most common site. Posterior compartment can also happen. So it is the most component is the anterior compartment of leg, and the most frequent injuries are in the forearm are a supracondylar fracture of humerus. These are the most two common injuries: tibial fracture, femur fracture, and humerus fracture. These are the three most common fractures associated with compartment syndrome. Clinical features is classically described as 5 P's: pallor, paresthesia, pulselessness, then paralysis, like that. But you don't have to remember the 5 P's. You remember the most common or the most clinching diagnosis for compartment is an acute onset pain, which is out of proportion to what it should be. If you look at the arm or the the leg or the arm, you have given analgesic, but the patient is having excruciating pain. That is the most specific symptom of a compartment syndrome. Why? Because by the time your compartment pressure has increased to greater extent and pulselessness, paresthesia, nerve damage has started, it is too late. So you have to intervene early. That's why identifying based on clinical picture like excruciating pain is very important. Obviously, you have to look at the pulse and the neural function. Nerve damage is there or not, pulselessness is there or not, any paresthesia is there or not. You have to look at it. And compartment syndrome can be associated with muscle breakdown. So rhabdomyolysis can be accompanied. So CPK levels can be high. How will you measure the compartment pressure? You can measure based on various techniques like a needle manometer, Wicks catheter. These are all simple devices like this, where one catheter is put inside the compartment. That could be a leg or it could be your forearm. Generally within 5 centimeters of the area of the fracture, not beyond that. and after putting the needle you just put the sheet inside and connect it to the transducer system, which tells you about the pressure. Generally saying, all the compartment pressures less than 20 is normal. If the pressure is exceeding 20, it is abnormal, and if it is exceeding 25 to 30 centimeters of water, it is definitely abnormal. That is a definition of compartment syndrome. I mean, definition pressure wise of compartment syndrome. There are various methods, like I said, needle technique, Weeks method, and various other techniques are there. But to be very frank, none of them have been shown to be very superior. If you have a suspicion that compartment syndrome is there, don't measure, just go for a fasciotomy. So the traditional recommendation for decompression was 30 millimeters, but it is traditional. If the patient complains of excruciating pain, just go for the emergency fasciotomy. That is the basic treatment of a compartment syndrome. Coming to the next most important topic of today is a traumatic brain injury. Anyone has any question or doubt till now, whatever I have taught, they can ask me. Otherwise, I'll start within next 1 minute. I'll start with the brain.
Sir, your class is so much good that you have to take it separately. We cannot take it so many things at same classes. It's my earnest request.
I can understand, uh, but the issue is that for a
This is
domain,
this
yeah,
is the second time I am just issuing myself for the next 6 months. Previously, your class was so much informative that I am just writing and writing, but still now I cannot cope up with you. It should be taken at least 4 classes. That means the
I can
upper
understand.
abdomen, lower abdomen, four
I
to
am
five classes.
okay. I'm taking
Thank you.
three classes because four classes and all would be a bit more in terms of the overall syllabus. And I'll share the PPT. You can listen to whatever I'm saying. You can take
Yes,
the
please share the PPT. How can we get the share the PPT?
I'll share it with the coordinator. They can share with you.
Thank you,
Yes,
sir.
okay, Dr. Avishek, we will share the PPT with the students. Thank you.
Okay. Now I'll start with the brain injury part, traumatic brain injury, and there are various concepts involved in the traumatic brain injury part. So please be attentive. So traumatic brain injury, definition wise, it is a complex disease involving the primary, and there are primary and secondary components of a brain injury, especially the secondary injury having a different anatomical, physiological, and different biochemical factors that causes different various forms of injury to the brain. This is what definition tells me. Not so important. The mechanism is could be a blunt trauma, that is obviously a head injury, head striking against a wall or something, or it could be because of motor vehicle accident, various ways. It could be penetrating injuries like a gunshot wound, like a stab wound, anything could be there. But the what is the most important thing for an intensivist to focus on is the secondary injuries. We cannot prevent or treat the primary injuries. Whatever has happened has happened. The person has gotten into a road traffic accident, his head is having a trauma, it could be various forms. What we can prevent is the secondary injuries. We have to prevent the hypoxia, the hypotension, the raised ICP, and anything that can have a secondary brain insult. So that is where the intensivist roles comes into play. Various forms of brain injuries can be there. One could be diffuse, involving the whole brain. What could be focal? Diffuse could be like diffuse concussion, diffuse axonal injury, diffuse blast injury causing cerebral edema, or it could be a baby that has been vigorously shrunken causing a shaken baby syndrome. Essentially saying that's basically because of the DAI types scenarios. And focal etiologies could be a focal subdural hemorrhage, epidural hematoma, subarachnoid hemorrhage, intraventricular hemorrhage. So various forms of focal pathologies could be there. Blunt injuries, there are formerly in forensic medicine we used to read these things. Coop injury and counter coop injury. Coop injury is because of direct trauma. Supposedly a person is driving and then suddenly something comes in front of the car and their head goes and bangs against the windshield. Because of this direct trauma or direct impact, they have an injury to the part of the brain, that part of the head that is directly touching the windshield. At the same time, on the exact opposite side of the brain, because the brain is a moving structure, the person's head comes at halt. The cranium is now stopping, but inside the cranium, the skull, the brain is moving. So brain now tries to move forward against the meningeal stretch against the arachnoid and the pia mater and all those things, and that causes a secondary injury exactly opposite to that of the primary site injury, that is known as the counter coup injury. So coup injury is the direct blow to the brain at the site of trauma. Counter coup injury is the indirect blow opposite to the site of trauma because of the stretch between the brain and the skull. And the other diffuse type that I was talking about, I'll just have a one or two slides on the diffuse axonal injury. It is important from trauma point of view is when do you suspect? Supposedly a patient has come with brain trauma. We don't know whether head trauma is there or not, but suddenly in day 2 or 3 you see that the patient is just not waking. Patient is hemodynamically stable, your acidosis is not there, no other major injuries, but you see their pupils are sluggishly reacting, brain is not swelled up or there is no cerebral edema much, but the patient is not waking up. This could be because of diffuse axonal injury. This is a injury within the brain, not bleed or something, within the brain at the white matter gray matter junction. And the way to diagnose is doing a MRI. So this is one of the areas where MRIs in an emergency can be done. It is generally a subacute, like generally is diagnosed 2 to 3 days after the acute injury. Pediatric population is the one where diffuse axonal injury is very significant. It can be classified based on the extent. The grade 1 DAIs is around the third ventricle. The parasagittal, the paraventricular ones are the mild ones. Second degrees is callosal. That is when the corpus callosal structures are getting affected. Diffuse lesions, and most common site could be a posterior body of the splenium. And if you have vital structure involvement like midbrain involvement, the medulla oblongata and the brainstem involvement, you get class 3 or grade 3 of diffuse axonal injury. Done with DIs. Now coming to the proper core topic discussion of the PBI. So as I was saying, the secondary brain insult is the one we are dealing with, and that we have to stop. What are the ways that secondarily a brain gets injured? It could be structural injury because of neuroinflammation, because of microtubular fracture at the cellular level, and different ways it can cause excitotoxicity. Sodium potassium ATPase pumps gets abnormal. The glutamate pathways gets excited and excitotoxicity can occur. Calcium levels within the cerebral cells or the brain cells, they get activated. They can also cause apoptosis, necrosis, and increase excitotoxicity. So, excitotoxicity, calcium flux is important, lipid peroxidation is important, structural damage, excitotoxicity because of calcium influx, lipid peroxidation, toxic proteinopathies like amyloid protein deposition, tau protein deposition, functional disintegration. Other than that, as I said, calcium, if it is elevated, then cellular apoptosis, necrosis, all these things also causes damage, neuroinflammation and mitochondrial dysfunction are also responsible. This secondary injury is, by the way, similar as stroke. Whenever a patient gets an acute ischemic stroke or a cerebral hemorrhage, all the secondary brain injury mechanisms are also the similar. How will you diagnose severity of injury? How will you assert it? So it is based on mainly the scoring system. We know that there are 3 or 4 scoring systems: the Glasgow Coma Scale, GCS Pupil, and the abbreviated injury scale, full outline of unresponsiveness 4 scale. These are the most commonly used scale. Based on GCS, we can diagnose mild, moderate, severe. How? If it is GCS of score of less than 8, I mean 8 or less than 9 means 8 or less GCS, and if the loss of consciousness is less than 24 hours, patient needing surgical intervention, they are categorized as having severe traumatic brain injury. Anyone having a GCS of more than 13 and mild amnesia, no neurological intervention is mild. Anything other than mild and severe is moderate. GCS of 9 to 12, some loss of consciousness but regained afterwards, abnormal study but not needing surgery. So we have to know what is severe traumatic brain injury. Severe is GCS of 8 or less, loss of consciousness less than 24 hours, plus minus surgical intervention. We know about Glasgow Coma Scale, not going to the detail. Now coming to the main foundation or the main body that has developed the traumatic brain injury guidelines is the Brain Trauma Foundation guidelines. The last guidelines came in the year 2020. So I will quickly go through the recommendations. This is very important for your exam point of view, and I will explain why they are important and how will you manage a patient in a practical scenario. So the recommendations are on these following topics: decompressive craniectomy, hypothermia, CSF drainage, hyperosmolar therapy, ventilation strategies. So these are all the topics. First comes to the main important. Where will you go for surgery in a brain injured patient? Where will you go for surgery? There are major two trials which are there. These trials are mainly important for academic residents. For aspirants, trial names are not so important, but I'll just describe them for the benefit, for the sake of completion. There are two trials, DECRA and Rescue Team. What are those? They have compared, this is the RCT, both of them are RCT. DECRA is bifrontoparietal decompressive craniectomy. So again I'll say, so the term is craniectomy. We have removing one part of the skull. That is, removing is craniectomy. When we create a hole but don't remove the skull part, it is known as craniotomy. Either both can be used, but in trauma we have to remove the part because the brain can be severely swelled. So you have to prevent cerebral edema and subsequent cerebral herniation. That's why you go for this. So decompressive craniectomy has been found to be associated with lesser mortality than medical management. However, something known as a GOSE scoring system. GOSE stands for just to I think it is there. GOSE stands for Glasgow Outcome Scale Extended. Glasgow Outcome Scale, that is basically a measure of how functional the patient is after discharge. That scoring is worse with decompressive craniectomy. So, in one word, decompressive craniectomy leads to lesser mortality in severely brain injured patients wherever it is indicated, but it also leads to more vegetative patients, patients having more comorbidities and vegetation. Another trial, rescue tip, they compared decompressive craniectomy in when tier 1 and tier 2 therapies. I'll come discuss in details about tier 1 and tier 2. Just bear with me. Tier 1 and tier 2 therapies of ICP management has failed. Now the patient has gone, patient is needing either a barbiturate coma versus decompressive craniectomy. Which one is better? Here they have found out that decompressive craniectomy was found to be associated with, again, less mortality, less ICP elevation. If the barbiturate coma is not working, again you can go for decompressive craniectomy. And decompressive craniectomy patients are also given barbiturate coma. It's not that they are not given the other therapies. How you devise the trial is what is different. But you have to remember that decompressive craniectomy slightly better in reducing mortality in severely brain injured patients. So this is what the trial showed. Continue stage 1 and 2 treatments plus barbiturates in the both group, that was the control, and the intervention group was decompressive craniectomy. What the intervention group did is a large unilateral frontotemporoparietal craniectomy not less than 12 into 15 centimeter size. Based on the rescue trip trial, the current BTF guideline says the exact same thing, that in case of severely reduced increased ICP, you have to go for decompressive craniectomy and the size of the skull bone removal should not be less than 12 into 15 centimeters. That's the first recommendation. So, extended Glasgow outcome score was better with craniectomy. Sorry, worse with craniectomy, but better mortality was seen with this. So, what does it say? Secondary. See, this is known as secondary DC. What is primary DC? Primary DC is when you go for decompressive craniectomy at the beginning. When you go for decompressive craniectomy, for example, in a patient with massive intracranial hemorrhage and ICP elevation, we call the neurosurgeon, they go for craniectomy. That is known as primary decompressive craniectomy. But whenever decompressive craniectomy is done as a secondary measure for rescue measure in a patient with severely raised ICP, it is called as rescue measure, rescue DC or secondary decompressive craniectomy. So it should be performed for late refractory ICP elevation to improve mortality, but it does not improve the favorable outcomes. In early refractory cases, as well as the overall functional outcomes are not better with DC. And in large FTC, that is not less than 12 into 15 centimeter is what is recommended, the grade 2A recommendation. So it is well accepted as a mode for secondary refractory raised ICP despite medical management. This is what the Gaussian score is there. It's based on how, whether the patient is dead, vegetative, severe disability, like that. Good score and bad score are there, not so important for that. Second, what is the role of hypothermia? So, one first rule that we have discussed is decompressive craniectomy for severely brain injured patient not responding to usual medical therapy, tier 1 and tier 2 therapy. Next, what is the role of hypothermia? No specific role of routine hypothermia in brain injured patient. Full stop. But there is some role of head only cooling. There is one trial which showed that head only cooling has some neuroprotective effects. So post traumatic brain injury, you can go for cerebral only cooling. But if the patient is not having temperature rise, you can just let it be. And if the patient is already hypothermic with severe brain injury, just keep the temperature like that. Don't rewarm the patient. Avoid rewarming in patients who are already hypothermic. Done with the temperature part. Now the interesting parts comes. What is hyperosmolar therapy in brain injured patient? Many a times you see that brain injured patients are started on mannitol and 3% saline. So when to start them, how to monitor them, and would you go for routine administration or not? So as the name suggests, hyperosmolar therapy, it is a tier 2 therapy. I'll come to the tier approach again. As I said, it is a tier 2 therapy for elevated ICP after normal measures of reducing the ICP has been done. Normal measures, I'll come to tier 1 description. So what are the agents? Either you can use a mannitol or you can use a 3% saline. The dose for mannitol is 0.25 to 1 gram per kg body weight, but mannitol has got some disadvantages. If you are interested in reading up, you can go in details about the mannitol's triphasic response. Mannitol is a hyperosmolar subject. When it goes through the body, immediately it causes expansion of the intravascular volume. Then it drives the water out of the brain cells, causing reduction in the ICP, and subsequently it then causes diuresis by osmotic measures, and then it causes hypotension and loss of intravascular volume. So there is a triphasic response, because of which it can cause elevation of blood pressure, it can cause hypotension as well in the later period, and there can be a, when there is hypotension, that is detrimental for the brain, especially brain injury patients. Again, so those things are detrimental for the brain. So mannitol, and it is contraindicated in patients with severely reduced ejection fraction, means heart failure with reduced ejection fraction patients, or patients with kidney disease. So you have to avoid that. So mannitol is kind of guarded. 3% saline, however, is slightly better in terms of reducing the peaks of ICP elevation. Once you have started 3% saline, the peaks of elevation of ICP beyond 22 is less. How will you monitor the 3% saline versus mannitol? Mannitol is monitored by looking at the osmolarity, serum osmolarity. That is how it is monitored. And 3% saline is monitored by looking at the sodium levels. So your sodium should be between 145 to 155. Now, importantly, so mannitol, when you are monitoring, the osmolarity should be less than 320. You have to send the serum osmolarity. How will you give 3% saline in these patients? There is a big confusion apparently, and many people don't know it. If you are giving for 3% saline for hyponatremia, you have to give it for an infusion over 10 to 12 hours. 3% saline, 8 to 10 ml per hour. That's the dose. But if you are giving it for ICP elevation, always go for boluses. And boluses are given over 10 to 15 minutes, not 1 hour, 2 hours. So if you are giving 3% saline for ICP elevation, you need the hyperosmolar effect and you need the acute decrease in the ICP. We need to wait for 12 hours for the effect to come. Always go for bolus of 3% saline in ICP elevated cases. Dose is 2 to 5 ml per kg of 3% saline. So adult patients generally 100 say to up till 300 ml of 3% saline you can give, and you have to monitor the 3% serum sodium levels. However, if you head-to-head trial-wise, and BTF guideline does not say that 3% is superior to mannitol as of now, but there are many data which suggest 3% is slightly better than mannitol in few patients, especially the refracted elevations or peaks of ICP, etc. So that is done with hypertonic solution. What about CSF drainage? So basic three things we have discussed. Now what is CSF drainage? CSF drainage is if a patient has come with severe brain injury and their intracerebral pressure is elevated, their intraventricular pressure is also elevated. So your Monro-Kelly doctrine tells us that the total volume of brain plus blood plus CSF is constant. So if your brain volume swells up, that is going to reduce the cerebral blood flow. So if you remove some amount of CSF, that will preserve some amount of cerebral blood flow. By reducing the CSF volume, you are giving some amount of some margin so that the blood volume can have a expansion amount or expansion level. So you have to remove CSF. You can directly put a catheter inside the lateral ventricle, that is known as EVD, external ventricular drain, or you can uh, uh, put a lumbar drain. Lumbar drain For a raised ICP is contraindicated. It can be done in other cases. So you can do a EVD. So EPD is intermittent or continuous drainage of intraparenchymal ICP. Challenges is that sometimes it is a blind technique. The neurosurgeon comes, they will they will do the they will remove the scalp hair, they will put some betadine, and they will have a landmark guided technique by which they will drill a hole into the brain, I mean skull, and they will put a catheter inside the lateral ventricle and then drain the CSF. That's a basic technique, but it is a blind technique ultimately in emergency. It can happen that they miss the lateral ventricle. They can also damage the brain structure, and in coagulopathy patients, they can cause brain hemorrhage. So these are the main drawbacks of EVD. So there is no class 1 or definite indication, but yes, there is grade 2A recommendation for putting a for CSF drainage in patients as a tier 2 approach. So as a tier 2 approach, you can go for it and you can drain it. Ventilation strategies. Always remember, again, conceptual thing and attention. If traditionally we used to read that hyperventilate in a patient who has a raised ICP. This is such a wrong concept. In a patient who has a severe traumatic brain injury, for the initial 24 hours, because of their brain is damaged, basically the brain and the parent and the blood brain interface, that is the blood brain barrier, is damaged. So the cerebral autoregulation is damaged. Cerebral autoregulation is the property by which brain cerebral blood flow is preserved despite your swings in the blood pressure. If your autoregulation is damaged, your cerebral blood flow and perfusion is dependent on your blood pressure. So, and blood pressure and cerebral blood flow. So your blood flow depends on the blood pressure and the carbon dioxide. Because carbon dioxide is a vasodilator, it increases the cerebral blood flow, and if it is reducing, it reduces the blood flow. So in the first 24 hours, you have to keep normocapnia. If you increase it beyond certain limit, it can cause vasodilatation, can cause increase in the ICP. If you reduce it too much in the first 24 hours, because it is not having autoregulation, it can cause cerebral ischemia. So don't target a PCO2 of 32 in the first 24 hours. Target 35 to 45 or 35 to 40 in the first 24 hours. Then, so normal ventilation and normocapnia is what is recommended. Hyperventilation to reduce PCO2 levels is done as a tertiary tier 3 approach, tier 3 measure in tier 2 measure, tier 2 measure in selected patients where the ICP keeps on elevated, however, despite your optimizing other things. Now coming to analgesia, sedatives and hypnotics, we have to keep the patient sedated in ICP elevated patients. We have to keep their neck neutral, head and elevated, and whenever you are suctioning, putting a suction for the tube into the tube, you have to push a sedative dose so that you have no, you can, at each and every point when this kind of pressure stimulus or pain stimulus comes, that can cause rise in the ICP, that can be detrimental. So you have to suppress the metabolism, you have to give sedation, you have to give analgesia. In sedation analgesic, especially sedatives, either propofol or barbiturate is preferred for raised ICP patients. Now the PTF guideline says that prefer barbiturate over propofol because propofol can cause propofol infusion syndrome. However, both of them are usually acceptable, equally acceptable as per the current literature. Both of them reduce the cerebral metabolic rate. They reduce the cerebral blood flow, but cerebral metabolic rate reduction is higher as compared to blood flow reduction, and therefore they maintain the cerebral protection. So it is again grade 2B recommendation that high dose barbiturate can be given at 5 mg per kg. Propofol can also be given at 5 to 5 mg per kg or hour infusion, and that is especially important. That high dose barbiturate coma is important for tier 3 approach. Refracted elevation. If you recap, rescue tip trial, that was different. That was the decompressive craniotomy versus barbiturate coma. I was discussing. So for tier 3 approach, at the same part where DC is used, you can use a barbiturate coma. Would you use steroids? No. No role of steroids in traumatic brain injury. Even it is harmful. The reference is CRASH 1 trial. That's it. Infection prophylaxis. If the patient is having traumatic brain injury, you have to give a antibiotic. These are one of the few indications where prophylactic antibiotics has to be given. One might ask why. Brain injured patients, they have high risk of developing ventilator associated pneumonia. The, the cause is not aspiration. The cause is alteration of the gut microbiome. Whenever the gut microbiome is altered, your bad bacteria go up, good bacteria go down. and you have all sorts of infection. And these patients have high risk of developing VAP and early VAP, less than 48 hours of intubation, and therefore you have to go for some antibiotic coverage in these patients. So there was level 2A recommendation. Even tracheostomy is also favored. Early tracheostomy. If the patient does come with GCS of 8, you see that the patient is severely having a severe frontal contusion. Surgeon has operated. Patient has an EVD along with post decompensation craniectomy. You know the patient is going to need long term ventilation. Don't wait for 7 days for the ventilation to continue. Then go for tracheostomy. Go for immediate tracheostomy as early as possible. So early tracheostomy within 72 hours of ventilation in patients who are deemed to be requiring higher or greater length duration of ventilation is beneficial in this group of patients. Early tracheostomy. Prophylactic antibiotics, yes, it is to be given as I said. And EBD, antibiotics impregnated catheters can be used, not so important for the topic. DVD prophylaxis. Now this is a very tricky thing. So DVD prophylaxis by means it is chemical or mechanical. Mechanical is using a DVT pump. Chemical is giving heparin or ultrafen or Clexane, that is enoxaparin to the patient. You cannot give enoxaparin or heparin in the traumatic brain injury at the beginning because it can cause hemorrhagic conversion. Now the interesting part is what to do. So DVT risk is very much high in TBI patients. TBI is a very, very high catabolic state, very, very hyperinflammatory state, and it can cause severe increase in the coagulation factors, coagulopathy, hypercoagulable state, and it can cause DVT. If you are not treating, not giving anything, almost 54% patients can develop DVT, and if you are giving only DVT pump, still 27% patients can have DVT. This is such a high risk. So you have to give DVT. When can we start an LMWH or a UFH is the question. LMWH or UFH can be started as long as the risk of expansion of intracerebral hemorrhage has been negated. So it can be started underline as early as 48 to 72 hours of brain injury. 48 to 72. How will you determine? If the patient has come to you, you go for a CT, you understand, okay, there is a intracerebral hemorrhage. At 24 hours, you again do a CT, you see the cerebral bleed side is not increased, and then you can start the UFH or the Clexane or the enoxaparin as early as 48 to 72 hours. But the real time data says that within 5 to 7 days, if there is a bleeding inside the brain, not small contusion like a EDH or an STH, still there is a chance of expansion of hematoma as per the Neurosurgical Society guidelines. So it is preferable to suggest start it after 5 to 7 days as per the practical guidelines is concerned, but the BTF says as early as 48 to 72 hours you can start. Next is DVT pump. Obviously, if you are not using DVT prophylaxis like chemical prophylaxis, pharmacological prophylaxis, we have to apply DVT pump as soon as possible. Now, what is seizures and post-traumatic seizures? Patients who come with traumatic brain injury are many a times given a dose of levetiracetam or phenytoin just like that. So there are indications of starting these two drugs, I mean anti-epileptic drugs, and indications of where to continue them, how to continue them. If the patient has had a trauma, any seizure that develops less than 7 days of trauma is called as post-traumatic early seizure, and any trauma seizure that develops after 7 days of trauma is called as post-traumatic late seizure. If the patient is having uh, there is a particular set of criteria, I'll just show you, in which patients are given seizure prophylaxis. Yes, these are the risk factors. If you can just yeah, it there, I'll just put it here. Sorry. Yeah. Yeah. So you can look at it. What are the risk factors? So not all brain injury patients require a levetiracetam or phenytoin dose. If the patient is having a GCS of less than 10, having a large focal lesions like an extradural hemorrhage, epidural hematoma, or an STH, or patient is having a depressed fracture, bone fracture, depressed fracture of the skull, or penetrating injury, someone has put a gunshot into the brain. These are the things which is associated with high risk of post-traumatic seizures, and you have to start anti-epileptics prophylactically. That is before the seizure takes place. Now understand the difference. Patient comes to you, Patient has loss of consciousness, GCS less than 10 and falling into the criteria. You start antiepileptics prophylactically. Patient has come to you and having seizure, you start the antiepileptics as a treatment measure. And patient has come to you without falling into the criteria of having this criteria or having seizure, you don't need to start antiepileptics. What does antiepileptic do? They reduce the chance of developing early post-traumatic seizure. Differentiation between early and late is 7 days. So, again I'll repeat, giving phenytoin or levetiracetam in a severely brain injured patient falling into these few categories would reduce the chance of early post-traumatic seizure less than 7 days. It does not reduce the chance of post-traumatic seizures more than 7 days. I mean, seizures developing after 7 days of trauma. This is very important concept. So question is, if the patient is having seizure, what will you do? You will obviously go for anti-epileptics and you will continue the anti-epileptics for at least 2 to 3 years. Or very easy answer is, you just ask the neurologist to take care of it. You don't stop it. If the patient does not have seizure but it is started prophylactically, you slowly taper it over next 2 weeks, the anti-epileptic drugs, and taper it and stop it after consulting the neurologist. You cannot stop the anti-epileptic drug just like that. You have to take a neurologist opinion and taper it. As per the BTF guidelines, phenytoin at 15 mg per, I think phenytoin dose I just forgot, I think it's 15 to 20 mg per kg body weight. Phenytoin is the preferred drug. However, and phosphonitoin is slightly better than phenytoin because of its water solubility and greater side effect potential, etc. But levetiracetam is currently being utilized, and many of the literatures are preferring levetiracetam because of its universal non side effect, avoiding, it has less side effects than phenytoin, lesser amount of drug interaction. So levetiracetam is also being used. There is insufficient evidence in this topic about what to use, but prophylactic phenytoin is not recommended to prevent late seizure, but it is recommended to decrease the incidence of early post-traumatic seizure. ICP monitoring. So somebody asked you that when you will go for ICP monitoring in these patients. So ICP monitoring is to be done in patients who have following criteria. Sorry. So ICP monitoring is done if the patient is having these criteria. Not all patients require ICP monitor. If a patient is having abnormal GCS and abnormal CT, patient obviously having CT scan showing a bleed, GCS is down, you have to go for an ICP monitoring. And ICP monitoring are various techniques. Here, what is recommended is putting an EVD. So EVD solves two purposes. It's CSF drainage as well as ICP monitor. You can directly monitor the cerebral pressure. Other techniques of ICP monitor is putting a brain parenchymal catheter. You can put a subdural catheter. You can look at the ophthalmic optic nerve sheath diameter, and you can use your transcranial Doppler. These are the various ways. I'm not going to the details of ICP monitoring, but here I'll focus on the part that if your ICP monitoring needs to be done if the patient has an abnormal CT, or if the patient is having a normal CT but 2 or 3 of this following: age over 40 years, unilateral posturing, and systolic hypotension less than 90 millimeters of mercury blood pressure. I'll again repeat, ICP monitoring is to be done if the patient is having a normal CT along with 2 out of 3 of age more than 40, unilateral motor posturing, and systolic blood pressure. Meaning to say that if the patient is falling into this criteria and severely brain injury you are suspecting, even if the CT is normal, you go for ICP monitoring. Now, what is the pressure that we are going to target? So pressure, in the systemic pressure, you are going to maintain an adequate MAP in order to maintain something known as cerebral perfusion pressure. Cerebral perfusion is the difference between the upstream, that is the MAP, and the downstream, that is the ICP. So MAP minus ICP is cerebral perfusion. The target for ICP is to be kept less than 22, and the target for MAP is to keep a CPP of 60 to 70. So a CPP of less than 50 is bad because does not supply the brain adequately, and CPP of more than 70 is also bad because it can also cause increase in the cerebral blood flow and cellular edema. So an adequate CPP should be 60 to 70. So if you are monitoring your ICP and ICP value is 22, you have to keep your MAP 22 plus 60 at least 82. If your ICP is 30, you have to keep your MAP at least 90. That is how you are going to decide on your vasopressor or the MAP. So a brain injured patient having a blood pressure of 110 by 60, MAP of 75, could be inadequate map to maintain an adequate cerebral perfusion pressure. Always keep a higher map in these patients. So, management using guideline way recommendation, CPP monitoring is recommended to decrease 2 weeks mortality. How will you monitor the cerebral perfusion or the cerebral parenchymal here? So there is no grade 1 recommendation. You can use something known as jugular venous oxygenation, bulb oximetry. So this is just like a central line which is put through the jugular vein, IJV, and then put retrograde towards the glomus. That is just beneath the your uh, the jugular fossa, and above that lies the glomus tubercle, above underlying the the inner ear cavity, and this one actually measures the global cerebral oxygenation. So the normal value is more than 70. If it is less than 50, it indicates severe global hypoxia of the brain. Cerebral autoregulation can be checked with TCD. This is an advanced concept. If I get time in the next class or somewhere later, I will tell you. And cerebral microdialysis catheter is also some techniques. This is a specially made catheter which measures cerebral pyruvate to lactate ratio. Pyruvate to lactate ratio. I'll tell. I'll give a small example later on. Okay. So I'll just give you example here only. What are the different catheters and all? Okay. I'll just go through this and then I'll come to the blood pressure threshold. Blood pressure threshold, what is the blood pressure I'll keep? So systolic blood pressure, diastolic, whatever has to be kept in order to keep an adequate CPP. Supposedly a patient with suspected traumatic brain injury has come to your doorstep, you are in the ED and you don't know the whether the what is the ICP, what is the MAP target. What systolic blood pressure should you keep? If the patient is, just remember, if the patient is middle aged, you can keep a MAP of 100. If the patient is young or old, you have to keep a higher MAP. If the patient is 50 to 69, keep a 100 MAP. Patient 15 to 49 or more than 70, 110 MAP. Question is, what happens less than 15 or more than 70? More than 70, the area is not defined. It could be individualized. Less than 15, it's mostly pediatric population. There is a that logarithm. There is a chart for normal blood pressure per age that is beyond the scope of this chapter. ICP threshold, you have to keep less than 22. One liner, simple that. CPP threshold, I have already told 60 to 70. Medical management, how will you manage a patient? So this is same as a general trauma management, airway, breathing, circulation. Indication of ICP monitoring, as I have just said, patients with less than 8 GCS, that is severe traumatic brain injury, abnormal CT or normal CT having 2 out of 3 of age more than 40, posturing and systolic blood pressure less than 90. Now, surgical management, I've already said about decompressive cranectomy. Now, MCQs, epidural hemorrhage, when you go for surgery. So, the answer is 2, 38. So, if you are 30 ml or more, the blood volume, that is the epidural hematoma volume, is more than 30 ml. By the way, a famous question comes about differentiating EDH and SDH. EDH is generally biconvex. It is lens shaped. It is situated between the dura mater and the cranium, and it is lens shaped and it crosses the suture line. It does not cross the suture lines. I mean, the anastomotic lines or the those lines are not crossed by the epidural hematoma. But subdural hematoma is sickle shape, and it is usually crossing the anastomotic or the the bridging lines, and it is sickle shape. So this is the basic two difference. So EDH of more than 30, GCS of less than 8, you have to go for surgery. SDH of more than 10 millimeters in thickness and GCS of less than 8 or motor GCS drop of less than equal to 2 or more than equal to 2, and any patient with pupillary abnormalities like anisocoria, you have to go for drainage of subdural hematoma. If you get frontal or multiple cerebral contusions, generally small contusions are benign. You cannot do, you just have to don't do anything. But sometimes if the volume is more than 30 ml, you have to go for operative intervention. Like if it is superficially situated, you can go for burr hole and evacuate. If it is deeply situated, you go for decompressive craniectomy. So the surgical intervention is also individualized, and it is based on how the patient's GCS is, motor power, and what is the cerebral pressure, what is the CT looking like. Decompressive craniotomy, we have already had the enough of discussion on that. Now coming to your important part of tier approach. Tier approach is would be the last topic for today's discussion. So what is tier approach? Now ICP elevation. If you ask me, somebody asks that what are the measures by which you can manage these patients to reduce ICP? Someone will say head and elevation, someone will say 3% saline, somebody will say I will adequately sedate and paralyze, someone will say I will start barbiturate coma, someone will say I'll go for surgery. So the CBIC, there is a CBIC guidelines is there. The body has come up with a tier approach in order to categorically strategize how you going to approach these patients and in what step you are going to apply what measures. So this is tier 0. So there are 4 categories of patients, not going into too depth, but just to tell you that ABCD. What is ABCD? ABCD stands for, if you're just look at this picture, I'll have a group slide overview. Patient has PbO2 and ICP. PbO2 stands for cerebral oxygenation, brain parenchymal oxygenation. This is measured by something known as either EVD or you can measure by Kumino catheters. Cerebral parenchymal catheters are there. It is placed just like placing an EVD, but it is much more easier because it is placed just beneath the skull and you are measuring the oxygen. Normally, it is beyond 50 is adequate, less than 40 is hypoxia, less than 20 is irreversible hypoxia. So that is PbO2. ICP normally is less than 15, 15 to 20 is raised, more than 22 is an emergency. So there can be 4 categories of patients. Class A is both PbO2 is more than 50 and ICP is less than 22. Class D, Class C having both PbO2 less than, PbO2 is bad, that is less than 50 and ICP is elevated more than 22. And Class D is having ICP which is elevated but PbO2 or oxygenation is bad. So just a quick trick. If your oxygenation is only ICP is normal but oxygenation is bad, you will increase the oxygen levels. So you increase the CPP, that increases cerebral blood flow, increase the FiO2. Doesn't work, then you increase the PO2 by increasing the FiO2, increasing the PEEP, decrease the ICP if you can. If it is still not managed, increase the cerebral perfusion. And lastly, if despite all these maneuvers it does not work, then you increase the PCO2. Why? Because your ICP is normal in this category. You just increase the PCO2 just to elevate your cerebral blood flow minimally and consider transfusion if your hemoglobin is less. That is the basic feature of this kind of patients. What is most important is to understand this category of patients, the class D, where all this tier approach is mostly important. A patient having a normal oxygenation but refractory raised ICP. That's what the question was. That brain ischemia has not occurred. If class D is there, brain ischemia has occurred. So it is a kind of irreversible stage. You have to decrease the ICP, you have to increase the CPP, you have to increase the oxygenation. Similar as class B. But class D is where ICP is elevated and PbO2 is normal. Tier 1, Tier 2 and Tier 3. What is Tier 1? First of all, what is Tier 0? Tier 0 you have to understand first. What is Tier 0? Tier 0 is to be applied in all patients with suspected TBM. So you have to admit in ICU, you have to adequately give analgesia to the patient, you have to go for head and elevation, you have to give a adequate sedation, not paralysis, sedation only, and temperature management so that you don't have hyperpyrexia or fever. Recommended intervention at this stage is just putting a central line, putting an arterial line to keep a track on the cerebral perfusion pressure, and send some blood electrolytes so that you don't have hyponatremia, optimize cerebral return. This is to be done in every patient. So osmolar therapy like 3% saline, those are tier 2 approach. Tier 1 approach is basic things: neutral neck, head and elevation, adequate oxygenation, adequate perfusion, keeping normal blood pressure, central arterial line insertion. This is tier 0. What is tier 3? Tier 1. So tier 1 is when this first approach does not work. In that case, what will you do? First, you maintain the CPP. CPP is not getting maintained. Then in tier 1, you have to put the EVD. So in patients with severely brain injured patients having indication of putting an ICP monitor, you have to put ICP monitor. This is part of the tier 1 before giving for 3% saline. So CSF drainage is tier 1. Then after you are transducing the ICP, you are monitoring the CPP. So you optimize the CPP to 60 to 70. You optimize your analgesia, you optimize your sedation. You keep normocapnia, that is 35 to 40. And if despite all these measures it does not work, you have to go for boluses of mannitol or normal or hypertonic saline. Boluses. But It is not around the clock. Many times we write 3% saline, QID, TDS, round the clock. It is not like that. At a measure, when it is indicated, it has to be given as bolus. And it is not a round the clock thing, intermittent boluses you have to give. If despite these maneuvers it is not managing the ICP, what will you do? You do a re-examine patients, see what if there is a basic thing is not going right, analgesia is not right, sedation is not right, your oxygenation is not right, lines are not right, neck is not all right. First you have to check all these basic things. If despite all these things are checked, still ICP is elevated, you go for three things. One is mild hypocapnia, neuromuscular blockage, and MAP challenge. I'll repeat: mild hypocapnia, neuromuscular blockage, and MAP challenge. These are the three therapies for tier 2 approach. And tier 3 approach is what we described in the first trial, DECRA trial, DC and barbiturate coma. So tier 3 approach has DC, decompressive cranectomy, barbiturate coma, and hypothermia, mild head cooling or mild hypothermia are tier 3 approach. So basic ICPA measures, putting a CSF brain is tier 1. Tier 2 has three things: mild hypocapnia, neuromuscular blockers, and your MAP challenge. And tier 3 is DC, barbiturate coma, hypothermia. I'll come to the individual thing. Now, what is mild hypocapnia? So, despite your normal PCO2, if your ICP is still elevated, but your brain is kind of having normal oxygenation, that means it is a vasodilatory problem. So, you reduce the PCO2 to slightly lower level to 32 to 35. That's why it is called mild hypocapnia, not severe hypocapnia. If despite that it does not act or does not is ineffective, then you go for neuromuscular paralysis. Routine neuromuscular paralysis in brain injured patient is not to be given. It is beneficial in patients in whom there is a evidence of ventilator patient asynchrony. I won't discuss about ventilator patient asynchrony here, but if the patient is having asynchrony, you have to give neuromuscular blockers there. And third is MAP challenge. What is MAP challenge? MAP challenge, I don't think I have discussed in details here. Just be attentive, I'll tell you what the MAP challenge is. So, MAP challenge is a technique by which you assess the cerebral autoregulation and also what is the optimal blood pressure for the patient. Now, imagine that supposedly patient, everything you have done, despite all the measures, patient is having a raised ICP of more than 22. Now you have done all the things, given saline, 30% saline, you have given mild hypocapnia. Now what to do? You can go for MAP challenge. So you start a noradrenaline or vasopressin infusion and you increase the MAP by not more than 10 millimeters of mercury than the baseline. Patient having a MAP of 80, you increase to 90 for around 20 minutes. 10 millimeters of mercury, 20 minutes. Now there are two scenarios. If the patient has an intact autoregulation and if the patient does not have impact autoregulation. What is autoregulation? If there is increase in the blood pressure, there is cerebral vasoconstriction and therefore there is prevention of increased cerebral edema. If there is hypotension, there is cerebral vasodilation, therefore the cerebral blood flow is maintained. This is autoregulation. So if your autoregulation is intact and if you increase blood pressure, it will cause very vasoconstriction in the brain and it will reduce the ICP. So if you increase the MAP and your ICP reduces, that is an adequate or normal autoregulatory response and that is a positive MAP challenge. It tells you two things. One is your cerebral autoregulation is intact and that you can increase your MAP by certain extent. There is a chance that you might increase the MAP, the cerebral perfusion also is better and that ICP is reduced because you are increasing the MAP. But if your autoregulation is not intact, then increasing the MAP will cause further cerebral edema and ICP will go up. In that case, you have to reduce the MAP so as to prevent further cerebral damage. This is a very, very conceptual test to understand. This is a test for autoregulation of the brain. There are various ways you can test the autoregulation like SPAR, the systemic pressure autoregulation control by measuring some TCT derived variables. TCT is transcranial Doppler. Again, these are all few advanced techniques, not so important for entrance purpose. And last but not the least, tier 3. Tier 3 are three techniques, as I said. Decompressive cranectomy and barbiturate coma, we have already discussed that these are all last stage therapies to be done only in, as I was saying that time, stage 1 and stage 2 therapies are failed. Refractory race. Refractory race definition is when tier 1 and tier 2 approach have failed. Then only you can tell them refractory race and you can do these two things. And mild hypothermia of the brain or can be done. So these are the things which is to be done. What are the things which are not to be done? Is that uh, uh, not to be done is giving mannitol as a non-bolus continuous infusion. Scheduled hyperosmolar therapy or giving round the clock just like that 4 to 6 hours a day. Lumbar CSF drainage is absolute contraindicated. This can cause cerebral herniation. Or giving Lasix or furosemide. Previously furosemide was there, but furosemide does not have any significant hyperosmolar effect or cerebral edema reduction effect. It is gone out of use. Steroids absolutely detrimental. Routine hypothermia, severe hypothermia detrimental. High dose propofol without looking at PIRS, that is propofol infusion, again not used. Routinely decreasing PCO2, especially in the early phase of traumatic brain injury, are not to be done. So all these things have been done. So few extra points that we can, it's good to know, is that EDH can have a lucid interval where patients behave normally between the event and the suspected abnormality or the unconsciousness, and during this phase they don't have the memory for this phase. They can go, they can do their normal work, they can go on anything, they do their normal life. Even there are reports that during the lucid interval people have gone and killed someone and they cannot be proven guilty because they were in lucid interval. They come back and then they become comatose. That's the lucid interval seen in EDH. And DI, as I said, DI is basically a white gray matter thing. It's a cellular damage and microvascular damage. Pathophysiology we have already discussed, and I think that's almost takes care of the entire topic. This is one representation of different catheters. This is the triple bolt introducing system. This is electrochemically fluorescent dependent neutrovent. This is just like a Kumino catheter, through which you introduce a special catheter inside the brain and measure the brain parenchymal oxygen. This is a microdialysis catheter. This is the dialysis catheter, basically introduced inside the brain. One might question what is dialysis and what is microdialysis. So imagine dialysis is like taking taking care of the cellular level in a larger way. What is the electrolytes? What are the urea creatinine in case of renal dialysis, renal failure? Microdialysis is putting a small catheter inside the brain and looking at its biochemical factors or cellular factors. So whenever your cellular oxygen level goes down, pyruvate level goes down, lactate level goes up. So if you are having a reduction in the pyruvate and increasing lactate, so that the ratio of pyruvate is to lactate is 1 is to 40 or more, that is an indication of irreversible brain damage. And this pyruvate lactate can be only measured root as a live measurement only by cerebral microdialysis catheter. How to check autoregulation? I'm not going to the details. One of them is map challenge. I've already discussed. It can be checked by your TCD. What are the other ways that we can measure your ICP other than obviously putting an EVD? Not always we put EVD. You can measure the optic nerve sheath diameter. If anyone is familiar with the thing, they can go and do it. Very easy to do. But PTF does not recommend optic nerve sheath diameter routinely because it is having a subjective component. So it does not routinely recommend it. And you can use a transcranial Doppler. It is a very simple thing. You can use a temporal window. You can look at the middle cerebral artery velocity. You can measure something known as pulsatility index. That is a surrogate marker of ICP, and that you can directly measure the ICP from the TCD without putting an EVD as well. But in 60 to 70% cases only you get a proper window. 30% you don't get a window. Plus there are a lot of other drawbacks of TCD as well. You might not get the machine itself. So this is all about the ICP monitoring. So ICP monitoring, invasive, non-invasive. Invasive are the EVD and the cerebral catheters, subdural catheters. Non-invasive are the TCDs and the optic nerve sheath diameters. That's it for the brain trauma foundation. I mean the cerebral brain injury, traumatic brain injury. Any question or any clarification that you want? I was planning to go for spinal cord injury as well, but today it is not possible. It is too much of information on a single day. I will cover burn and spinal cord injury in the next class. Any question or any clarification you want?
Sir, last question. If a brain trauma patient came to us with acute LVF, that creates a much more problem.
Okay. So
And
it's
with that, we have intubated the patient and trauma-induced ARDS. Those cases are very difficult to manage in OT also. At
right.
that time, what we can do it. Thank you, sir.
Okay. So this is a, these are all specific scenarios, and as you said, these are all very difficult scenarios. If you are getting a patient who is having a raised ICP and acute LVF, supposedly ejection fraction is 30%, then your go-to agent, the only difference comes in the what you will use as a 3% saline or mannitol. So you use a 3% saline. Here is preferable because you have the chance to monitor your 3% sodium levels. Rest everything is same. Your fluid management, obviously fluid management, you have to look at your you do a focus, lung ultrasound and heart. Not that your 35% heart failure is cannot be hypovolemic. They can also have hypovolemia. You have to monitor your lung ultrasound, IVC, echo. If you see that the lung pulmonary edema is developing, so your fluid resuscitation should be stopped. In patients, one thing I must mention, that if you suspect brain injury, your go-to fluid for resuscitation is normal saline. That is for any brain injured patients. If you're not suspecting brain injury, you can use Ringal lactate or cap or any balanced solution as well. So you will start fluid resuscitation. You will follow the trauma guideline, trauma maneuvers as similar as that. Your initial fluid should be 500 ml, not 1 liter. If you have an LVF, then if you see the patient is going into pulmonary edema, you stop the routine fluid administration and you go for 3% saline administration. It again depends what is the patient's urine output, what is the patient's blood pressure, and lot of other things. You maintain an adequate map so that CPP is maintained, and then you give a 3% saline bolus and monitor the 3% saline levels. But yes, 3% saline can also cause pulmonary edema because it is also an hyperosmolar product. But you have to weigh the risk and benefit. You have to keep on looking at the ultrasound and urine output and everything, and then you can go for 3% saline. One smart way to get around this problem is that if the patient is anuric, you cannot give 3% or mannitol. Patient is having LVF, you go for dialysis. You go for dialysis, keep the sodium in the dialysis at high. You keep the and hyperosmolar therapy indirectly can also be given by that route. That is one way. Second thing that approach you asked is trauma ARDS and raised ICP. Very difficult scenario to manage. And so, what is the problem with that? ARDS causes an acute cord pulmonale, okay, and it causes difficulty in ventilation. So, if you ventilate too much in ARDS, you are going to damage the lung. If you don't ventilate adequately, permissive hypercapnia is not allowable in these patients because traumatic brain injury patients are contraindication for permissive hypercapnia. So then problem comes ki what can you do? So option is that in these cases you can do 3-4 things. One is you can go for mild hypothermia. As I said, hypothermia reduces the CO2 production. If your total body CO2 production is reduced, then your PCO2 will be reduced and your brain will also have lesser amount of ICP elevation. So you treat fever, you give paracetamol round the clock, reduce the temperature so that reduce the metabolism. And other than your normal things, you cannot go for prone positioning. So if your severe ARD is there, you go for ECMO. But again, if you are going for ECMO, you cannot go for anticoagulation in the 24 to 48 hours after the trauma period. During this time, there can be increased chance of clot and everything. So that is a problematic thing. But yes, if you really ask me, ECMO can be a fallback option. And last thing to consider here is that imagine a patient having severe traumatic brain injury of GCS less than 8 along with a lung injury, severe ARDS, PF ratio of 50 to 60. This patient is anyways going to die, unfortunately. Why? Because patient is having a severe brain injury and your ARDS is causing severe hypoxia, that is also contributing to secondary brain insult, and severe brain injury also causes some amount of pulmonary edema because of that. So all this cumulatively causes severe damage to patient's brains and lungs altogether, and you are having nowhere to go. So in these patients, you have to accept a unfortunate outcome. This is what I can add to specific scenarios like that.
Sir,
Okay,
the PowerPoint slide present, share it, share for the slides, sir.
yeah, I'll share
Thank
it.
you, sir.
Actually, last slide I could not share because it was 1/3 of the class. Today I will share it. You read for yourself. And Burns topic I have not yet to make it, so that I will be shared after the classes. So I guess that's it for the day. Thank you.
Thank you, sir.